Welcome to our lecture. Today, we will examine eCTD Module 1, focusing on regional and international requirements and administrative documents. This module is critically important as it serves as the administrative gateway to your entire drug submission. Unlike the other modules which are harmonized across ICH regions, Module 1 remains largely region-specific, making it essential for regulatory professionals to understand the nuances of each major market. Today we will explore the structure of Module 1 across the FDA, EMA, and PMDA, examining both the similarities and key differences that affect your submission strategy. Our agenda today covers 6 major areas. We will begin with a refresher on the CTD pyramid structure to establish context for where Module 1 fits within the overall submission architecture. Next, we will examine ICH-M4, the guideline that governs the organization of the Common Technical Document. The core of our discussion will be a detailed examination of Module 1 itself, followed by a comparative analysis of the regional table of contents for the US FDA, European EMA, and Japanese PMDA. We will pay particular attention to FDA forms and documents given their importance for US submissions. Finally, we will summarize key takeaways that you should remember for both your written assignment number 1 and your professional practice. Let us begin by refreshing our understanding of the CTD pyramid structure. This foundational knowledge is essential for understanding where Module 1 fits within the broader context of pharmaceutical submissions and why its regional nature creates both challenges and opportunities for global drug development programs. The CTD pyramid represents the organizational structure of electronic common technical document submissions. At the top, highlighted in orange, sits Module 1, which contains regional administrative information. This is notably marked as not part of the harmonized CTD because each region defines its own requirements. Module 2, shown in purple, contains the CTD summaries including the Quality Overall Summary, Non-Clinical Overview and Summary, and Clinical Overview and Summary. These summaries provide high-level assessments of the data contained in the lower modules. The base of the pyramid consists of Modules 3, 4, and 5 which contain the actual technical data, Module 3 for quality or CMC information, Module 4 for non-clinical study reports, and Module 5 for clinical study reports. These lower modules are common across all ICH regions, meaning the same documents can be submitted to FDA, EMA, and PMDA without reformatting. Module 1 serves as the administrative cover page for your entire eCTD submission. It provides all the regional and country-specific information that regulatory authorities need to properly process your application. This includes the name and contact information for the pharmaceutical company sponsoring the application, key personnel such as the lead regulatory contact and medical contact, and information about all entities involved in conducting the research. Think of Module 1 as essentially the master cover page that will guide reviewers in how they properly organize and prioritize their review of your submission. The information here sets the tone for the entire regulatory interaction, making accuracy and completeness absolutely critical. Remember that ICH-M4 governs the overall CTD structure, but Module 1 is the one area where harmonization remains incomplete, requiring careful attention to regional requirements. Now we will dive deeper into ICH-M4 and examine how Module 1 is structured across the 3 major ICH founding member regions. Understanding these regional differences is crucial for companies planning global submissions, as the same product may require significantly different administrative packages depending on the target market. ICH-M4 has been implemented globally across many regulatory authorities. The 3 founding ICH members, the United States FDA, European Commission through EMA, and Japan's MHLW through PMDA, have all formally implemented the guidance. The FDA implemented in October 2017, Europe in July 2016, and Japan in June 2017. Other significant regions include Health Canada, which implemented in June 2012, Singapore's HSA in November 2016, Korea's MFDS in June 2016, and China's NMPA in February 2018. The critical point to remember is that while Module 1 is somewhat harmonized, it is the one part of the eCTD that is not as strictly defined in the ICH reference document. This means individual regions define Module 1 largely for themselves, creating variations that regulatory professionals must navigate carefully. For FDA submissions, the Module 1 Table of Contents follows a specific structure defined in the Comprehensive Table of Contents Headings and Hierarchy document, version 2.3.1. Section 1.1 covers all required forms including FDA Forms 1571, 356H, and 3397. Section 1.2 is for cover letters that introduce and contextualize your submission. Section 1.3 contains administrative information including contact and sponsor details, and any changes to address, agent, sponsor, or transfer of obligations. Section 1.4 covers references including letters of authorization and cross-references to previously submitted information. Sections 1.5 through 1.8 address regulatory pathway information including application status for withdrawals and reactivations, meetings for FDA interaction documentation, fast track for expedited pathway requests, and special protocol assessment requests for clinical, carcinogenicity, and stability studies. Continuing with the FDA Module 1 structure, Section 1.9 covers pediatric administrative information including waivers, deferrals, and exclusivity determinations. Section 1.10 addresses dispute resolution procedures. Section 1.11 is for information amendments covering quality, non-clinical, and clinical updates that do not fit elsewhere. Section 1.12 captures other correspondence with FDA. Section 1.14 is critically important as it contains all labeling information including draft and final labels, package inserts, and labeling history. Section 1.15 covers promotional material for both launch and non-launch materials. Section 1.16 addresses risk management plans including both non-RMS and REMS documentation. Sections 1.17 through 1.20 cover post-marketing studies, proprietary names, emergency use authorization documentation, and the general investigational plan for initial IND submissions. Understanding the specific FDA forms required for Module 1 is essential for successful submissions. For IND applications, Form FDA 1571 is the primary application form at 3 pages covering all essential information about your investigational drug program. Form FDA 3674 provides clinical trials certification of compliance. Form FDA 3397 is the user fee cover sheet, but note that you need an FDA user fee account to generate this form. Form FDA 2252 is the annual report transmittal for ongoing IND maintenance. For NDA applications, Form FDA 356H replaces the 1571 as the primary application form for marketing authorization. The NDA also requires Form 3397 for PDUFA user fees, Form 2253 for transmitting promotional labeling materials, and Form 2567 for transmitting final labels and circulars. All forms are available at the FDA Forms webpage, and I strongly encourage you to familiarize yourself with each form's requirements before preparing submissions. The Comprehensive Table of Contents Headings and Hierarchy, version 2.3.1, is perhaps the most critical reference document for FDA eCTD submissions. This document provides a granular listing of all expected sections for Modules 1 through 5, specifically designed for IND and NDA submissions. It includes detailed heading hierarchies showing exactly how to structure your submission. The document also contains mapping appendices that show precisely where each type of document should be placed for both INDs and NDAs, with references to the applicable Code of Federal Regulations citations. A crucial concept to understand is that not every heading is applicable to all submissions. You must only include information under headings that are relevant to your specific application. Additionally, remember that eCTD submissions to FDA are living documents. Your IND is essentially a dress rehearsal for the NDA, evolving as you gather more evidence about your drug through the development process. FDA offers 4 distinct expedited pathways that are documented in Module 1, specifically in Section 1.7. Fast Track designation facilitates development and expedites review for drugs treating serious conditions with unmet medical need, and importantly makes the application eligible for rolling review. Breakthrough Therapy designation is for drugs showing substantial improvement over available therapy based on preliminary clinical evidence, and provides intensive FDA guidance throughout development. Accelerated approval allows approval based on surrogate endpoints reasonably likely to predict clinical benefit, but requires post-approval confirmatory studies. Priority review sets an FDA goal to take action within 6 months instead of the standard 10-month review timeline. Understanding these pathways and properly documenting requests in Module 1 can significantly impact your development timeline and regulatory strategy. Now let us turn our attention to the European Medicines Agency and examine how Module 1 is structured for EU submissions. While there are many similarities with FDA requirements, there are also important differences that reflect the unique regulatory environment and priorities of the European Union. The EMA Module 1 structure follows a similar pattern to FDA but with some notable differences. Section 1.0 is the cover letter, 1.1 contains the comprehensive table of contents, and 1.2 is the application form which must be submitted using the mandatory electronic application form or EAF. Section 1.3 covers product information including the summary of product characteristics or SPC, labeling, package leaflet, mock-ups, specimens, and notably Braille requirements for accessibility. Section 1.4 requires information about the experts involved in quality, non-clinical, and clinical assessment. Section 1.5 addresses specific requirements for different application types including bibliographical applications, generic or hybrid applications, data and market exclusivity, exceptional circumstances approvals, and conditional marketing authorization. Section 1.6 uniquely requires environmental risk assessment for both non-GMO and GMO products. Sections 1.7 through 1.10 cover orphan market exclusivity, pharmacovigilance including risk management plans, clinical trials information, and pediatric requirements. Comparing US and EU Module 1 requirements reveals both similarities and important differences. Both regions require application forms, though FDA uses 1571 or 356H while EMA uses the electronic EAF. Both require labeling information, though the format differs with EMA requiring the summary of product characteristics. Patent certification is specific to FDA while EMA requires information about the experts involved in the submission. FDA requires debarment certification while EMA uniquely requires environmental risk assessment. Both regions accept letters of authorization and require labeling text, and both have mechanisms for risk management though EMA's pharmacovigilance requirements are more explicitly defined in Module 1. The color coding on this slide shows orange for region-specific requirements and green for requirements that are similar in both regions, helping you visualize where the differences lie. Japan's PMDA takes a notably different approach to Module 1. A key technical distinction is that PMDA uses XML schema rather than XML DTD for Module 1 definition, which has implications for how submissions are validated and processed. The Japanese application form is considerably more CMC-heavy than its US or EU counterparts, containing detailed information about product name, ingredient and contents, manufacturing process, dosage and administration, indications, storage and shelf life, specifications and testing methods, and manufacturing sites. This means that much of the content that would appear only in Module 3 for US or EU submissions must also appear in Module 1 for Japan. In fact, the Japanese Module 1 duplicates much of Module 2.3, the quality overall summary. For companies pursuing Japanese market authorization, I strongly recommend working directly with Japanese consulting firms who understand the local requirements intimately and can ensure your submission meets PMDA expectations. This comparison table summarizes the key differences across the three major ICH regions. For key reference documents, FDA relies on the C2CH version 2.3.1, EMA uses UDRALEX Volume 2B Notice to Applicants, and PMDA has its own regional implementation guide. The main application forms differ significantly. FDA uses Forms 1571 and 356H, EMA uses the Electronic Application Form, and PMDA uses a CMC-focused application form. Unique features include FDA's expedited review pathways documented in Module 1, EMA's environmental risk assessment and Braille requirements, and Japan's extensive CMC detail requirements. From a technical format perspective, both FDA and EMA use XML DTD while Japan uses XML schema. Despite these differences, all regions continue working toward greater harmonization of Module 1 content, which should eventually simplify global submission preparation. There are 4 key takeaways I want you to remember from today's lecture. First, Module 1 is region-specific. It is the only part of the eCTD that is not strictly defined by ICH, meaning each region sets its own requirements and you must understand these differences. Second, your IND is your NDA dress rehearsal in the US. The IND evolves into your NDA as evidence accumulates through development, so plan your IND structure with the end goal in mind. Third, the C2CH is critical for FDA submissions. Version 2.3.1 maps exactly where documents belong, and you should reference it constantly when preparing submissions. Fourth, know your regional forms. FDA uses 1571 and 356H, EMA uses the electronic EAF, and PMDA has CMC-focused application forms. Understanding these forms is fundamental to successful submissions in each region. To summarize today's lecture, Module 1 serves as the region-specific administrative cover page for eCTD submissions, providing all the sponsor information, forms, and regulatory documentation needed for authorities to process your application. The US and EU have similar general content with structural differences and minor region-specific requirements like FDA's expedited pathways and EMA's environmental risk assessment. Japan's approach is markedly different with its CMC-heavy application form that includes content also appearing in Modules 2 and 3. Despite these differences, all regions that have formally adopted eCTD continue working toward harmonization of Module 1 contents. Key resources you should bookmark include FDA's C2CH version 2.3.1, UDRALEX Volume 2B, ICHM4 guidelines, and the various regional implementation guides. Here are the key references for today's material that you should consult for your written assignment and professional development. The FDA website at www.fda.gov contains all forms and guidance documents. The ICH website at ich.org provides the M4 guidelines and other harmonization documents. The EMA eSubmission portal at esubmission.ema.europa.eu has European-specific guidance. You should download and familiarize yourself with the FDA Comprehensive Table of Contents Headings and Hierarchy version 2.3.1, the EU Module 1 eCTD Specification version 3.0.2, and the ICH Change Control Process for the eCTD version 1.9. For Japan-specific guidance, consult the Regional Implementation Guide. Thank you for your attention today. Are there any questions about Module 1 or the regional differences we discussed?